Good morning. My name is Jim Bellew, and I'm a physical therapist and professor at the University of Indianapolis, where I teach in the areas of human and applied physiology and biophysical agents. I'd like to thank Dr. Davi, Tammy Nelson, and the other organizers of this conference for the opportunity to be here today, and I'd particularly like to thank Dr. Davi for his recognition of the role of biophysical agents in non-opioid pain management. I would like to remind the attendees of this conference that they can submit questions to me in the section below, and I will look forward to answering those for you as we can. Okay, so first, what are biophysical agents? Biophysical agents represent thermal, mechanical, electromagnetic, acoustic, and light energies. These may be more popularly recognized as thermal agents, cold and hot packs, mechanical agents such as traction or compression, or electrical modalities such as electrical stimulation, or pulsed electromagnetic fields. Acoustic energies manifest as ultrasound, and of course light energies are most commonly recognized as laser. Now collectively, these biophysical agents are used to elicit biophysical effects. Now these biophysical effects manifest themselves at the cellular, tissue, and whole body level. I've provided a few examples here. One on the far left being galvanotaxism, or the migrational or directional influence on cell populations in response to some biophysical energy. A particular example demonstrated here are cells in response to an applied electrical field. And we see this galvanotaxic effect in cells such as epithelial, endothelial cells, myofibroblasts, macrophages, neutrophils. Another type of biophysical effect that we commonly use is known as photobiomodulation. This implies the change or influence on cellular activity in cells particularly responsive to light or photon energy. And we particularly see this in the mitochondria, where we see an amplified production of ATP, nitric oxide, and reactive oxygen species. But more specific for today's event, we're talking about biophysical agents and their role in analgesia. We know that biophysical agents have properties capable of eliciting activity in ascending and descending neuroinhibitory pathways that help provide analgesia. And that will be more the focus of our topic in this lecture. So, in order to understand the role of biophysical agents in pain management, I believe it is requisite to have some fundamental understanding of the origins of pain, and then we can better understand how biophysical agents can be used to intervene with that pain. Nociceptors represent our neuroanatomical structures of the peripheral nervous system, which are responsible for the initial detection and transduction of physical stimuli into a neurosensory signal that is then conveyed or propagated through the peripheral nervous system and then to the central nervous system for eventual interpretation of pain from that original neurosensory signal. And these nociceptors are located throughout the body, in the skin, muscle, joints, bone, viscera. And they have a relatively high activation threshold, which means that we can sustain a reasonable amount of physical stimuli, such as standing on our feet for long periods of time or sitting on our buttocks, without necessarily transducing that mechanical compression into signals later interpreted as pain. These peripheral free nerve-ending nociceptors are further classified into the designation of A delta and C fibers. These peripheral free nerve endings also are the very same nerve endings which are impacted through the administration of local anesthesia or local anesthetics, which functionally block the sodium channels, thus blocking the conveyance or propagation of that neurosensory signal created by the transduction of the physical stimulus. So C fiber type of these nociceptors are unmyelinated and slow conducting. The relevance of this will be developed very soon in its application to biophysical agents and pain management as well. They're unmyelinated and thin, and that makes them slow conducting. and they respond to a broad range of stimuli, including mechanical, thermal, or chemical. Thus, they're referred to as polymodal. And it is these C fibers that convey sensations classically described as dull, throbbing, aching, and burning type pain. In addition to the C fibers within our nociceptive peripheral field, we have the A delta fibers. These are thin but a slightly larger diameter, and they are myelinated. Thus, they are faster conducting. And again, the relevance of this I will get to very soon. These A deltas specifically respond to high intensity mechanical and thermal stimuli and convey the classic descriptions of sharp, stabbing, pricking. So the real world understanding or applicability of this falls this way. Faster conducting neurosensory input on the A delta fibers is known as first pain because it has a quicker onset but a shorter duration or experience. And C fiber mediated sensation or nociceptive input is known as second pain, which has a slower onset but has a longer lasting characteristic. So when you stub your toe or drop a dumbbell on your toe or close a door or a car or a window on your thumb or get hit on the head, preferably not by a hammer, that initial sharp, stabbing, pricking pain that is felt right away is mediated by the A delta fibers. But that dull, throbbing, aching pain that persists for hours and even days sometimes is mediated by the C fibers. Now, within our peripheral afferent sensory field, we don't have only nociceptors. We have non-nociceptors, and this nerve group class is called the A betas. These are also myelinated and slightly even larger diameter, which makes them even faster conducting than either the A delta or the C fibers. These A beta cutaneous sensory nerves convey the classic descriptions of touch, pressure, and vibration, and are appropriately named after those that originally observed these neurosensory organs. Now, with injury or insult to the tissue, tissues release a whole slew of endogenous chemicals, some of which are noted in this table for you, a few with the blue arrows that may sound more familiar to you, such as prostaglandins, substance P, maybe serotonin. These chemicals, when released from damaged tissue, act to reduce the activation threshold of those A delta and C fibers, which typically have a higher activation threshold. And this reduction in the activation threshold sensitizes the nerves, making them more easily depolarizable or more easily activated in the presence of mechanical stimuli. And this is what is known as peripheral sensitization. Said differently, things that did not once hurt now do hurt, and perhaps things that did not once hurt as much as they do now. So in order to understand how biophysical agents play a role in pain modulation, I think we need to look at some of the history of our understanding of pain modulation. So it was in the mid-60s when Drs. Melzack and Wall proposed an idea that it was activation of local inhibitory circuits in the spinal cord that inhibit or block or gate the transmission of neurosensory input from the A delta and C fibers. And that this gating control of pain was based on the quantity of input between the smaller A delta and C fibers and the larger A beta fibers, the input into the spinal cord. And the idea was that A beta input, again, touch, pressure, vibration, conducted on the A beta faster conducting nerves would reach the dorsal horn of the spinal cord sooner than the slower conducting A delta and C fibers. Now, more recently, or since Melzack and Wall, our understanding of the neuroanatomy of the spinal cord has led us to understand that the gray matter of the spinal cord is divided into 10 layers, termed Rexed lamina. And we know that A delta and C fibers synapse in the more dorsal lamina 1 through 5. But we also know that the A beta fibers have their terminal projections into a deeper lamina, lamina 3 through 6. Furthermore, we understand that lamina 3 and lamina 2 is comprised of a large number of neuroglial cells and unmyelinated nerve cells that were originally observed and described as having a very gelatinous appearance. Subsequently, this region of the dorsal horn was described as the substantia gelatinosa. We now understand that this region is a densely packed region of interneurons. And this region of interneurons seem to have an inhibitory effect on the terminal inputs or projections of those A, delta, and C fibers, which again are our nociceptive fibers. Now, according to the original gate theory, activation of the A beta fibers, again, the touch, pressure, vibration sensations, this input sends collateral branches to the substantia gelatinosa, which turns it on or excites it or makes it more active. And that then allows the substantia gelatinosa to do what it does as interneuronal inhibition of the inputting A delta and C fiber. However, if A delta and C fiber predominates, this sends inhibitory projections to the substantia gelatinosa, thus turning off the substantia gelatinosa. Therefore, we would lose that inhibitory or blocking or gating effect originally described by Melzack and Wall. Now, the real world application of this is as such. With C and A delta fiber input, this collectively acts to inhibit the interneuronal pool of the substantia gelatinosa. When the interneuronal pool of the substantia gelatinosa is inhibited by A delta and C fiber input, we lose the inhibitory or gating effect of the substantia gelatinosa on the transmission or propagation of the sensory input coming from the C and D fibers. And thus, input from the A delta and C fibers is free to traverse to the second order neurons for eventual conveyance to higher order brain centers for interpretation of pain. Now, in contrast, A beta input, again, touch, pressure, vibration, it sends excitatory input or excitatory signals to that substantia gelatinosa, exciting or turning on or activating that interneuronal pool, which in turn sends an inhibitory signal to the second order neuron, effectively blocking, turning off, or gating that A delta and C fiber input. But we all discovered this as small children, believe it or not, because we knew back then that when we had an injury, if mom kissed it or rubbed it, it felt better. We knew that we could rub off a pain if we stubbed our hand or stubbed our thumb or hit it with a hammer. And we learned to shake it off many, many years ago before we knew anything about neurophysiology. And this is where biophysical agents become recognized for their role. Biophysical agents for pain modulation provide a large amount of A beta input. So there are simply too many biophysical agents to be able to address in one session. However, I have selected one burgeoning agent, two commonly used physical agents, or biophysical agents, but with some misunderstandings that I would like to maybe present or clarify, and a fourth biophysical agent, which is probably the most widely used biophysical agent in the world for non-opioid pain management. So laser. Laser implies the application of light energy. Again, biophysical agents are the application of physical energies, in this case, light energy. Now, initial FDA approval for laser, or more appropriately named low-level light therapy, came in 2002 for carpal tunnel syndrome. And since then, FDA approval has been expanded for a wide variety of other general musculoskeletal uses. However, I continue to describe laser or low-level light therapy as a burgeoning agent, particularly here in the United States, where for a few reasons we have much less recognition, use, and study or research of light therapy in contrast to other parts of the world, Middle Europe, South America, particularly Brazil, Australia, New Zealand, where we see a lot of our supporting evidence coming from. Now, currently in use in the United States are what are known as low-level, cold, non-thermal, or therapeutic lasers, classified as Class A or mostly Class B. And these would be in the 5 to 500 milliwatt range, if that's familiar to you. However, this Class 3 differs from what is defined as a Class 4 laser, as Class 4 lasers are recognized as surgical, hot, or thermal lasers. Now, more recently in the United States, and particularly in the fields of rehabilitation, we have seen the emergence of Class 4 lasers advertised for therapeutic purposes. However, majority of these have had, the manufacturer has truncated the peak power output or widened the beam diameter to more closely reflect that of a Class 3B laser. However, what remains is that today's advertised Class 4 lasers work through thermal activity or heating agent, and therefore Class 4 lasers in therapeutics are considered more a thermal agent. They do not work through light therapy as a Class B laser. So the physiologic effects of low-level light there are exactly that, through the application of light energy. Photons. Photons are packets of light energy. And this is neither the time nor place to go into the mechanics of laser, but we're talking about amplification of light, and it releases photons of energy, these packets. When these photons of light energy are released into the tissues, certain tissues have a certain affinity for these photons. The mitochondria is one of these type of organelles, and particularly cytochrome C oxidase, which is the last stop in the electron transport chain. This particularly is responsive to that photon energy. Then in the mitochondria, we see a variety of amplified activities. We see increased production of ATP, nitric oxide acting as a very potent vasodilator, thus increase in microcirculation. And we see reduction of substance P, that one of the pivotal critical neurotransmitters involved in the neurosensory experience of pain. Also with laser, but apart from analgesia, is we see a large variety and great evidence supporting biophysical effects with tissue healing. Again, not directly related to analgesia, but with tissue healing can come analgesia in many cases. Now, evidence for laser comes from a wide range of systematic reviews from a variety of different sources. And here are a few evidencing the use of low-level light therapy for a variety of musculoskeletal conditions, but also a wide range of support for low-level light therapy's use in tissue healing. Now, laser, I mentioned earlier, is much more widely studied throughout the rest of the world than here in the United States. And when we look at some of the major, more recent systematic reviews for pain modulation in musculoskeletal conditions, we clearly see, as exampled here, typified, this is a good example of the literature. These are from outside the United States. So the reality for laser in the United States can sort of be summarized as this. The FDA continues to restrict or limit the wavelengths of use here, allowed to be used here in the United States. So we are behind in our application and use and recognition of laser from other parts of the world. Currently, there's very poor or no reimbursement for laser through third-party reimbursement parties here in the United States. I would suggest that there also continues to be relatively poor understanding of not only the mechanisms of laser, but also the application and clinical use of laser. And partly because of any one of these previous three described factors, there's a large degree of bias against acceptance by clinicians. And so collectively, these have limited the use of laser here in the United States. But I do believe, and I still call the laser a burgeoning agent, because I think based on the evidence in other parts of the world, I think we will see increased use of laser here in the United States. Let's switch to traction now. Traction is the application of mechanical or tensile energy. Application of traction or pulling force using some sort of mechanical or otherwise system. Now, there are a wide variety of proposed physiologic effects from traction, but collectively they all contribute to provide analgesia, whether that be through widening of the intervertebral foramen, tensing of the ligaments, or stretching of the spinal muscles. I will bring this back to say collectively all of these things provide a great deal of A-beta input. A-beta input, touch, pressure, vibration, flooding that dorsal horn region that we looked at previously with the neuroanatomy. So there are a wide variety of types of traction that are available to your patients. Mechanical traction is perhaps the most widely recognized and is largely clinical based. And this is the use of a motorized production of traction, some type of motorized programmable device. And mechanical traction takes two forms, continuous or intermittent. Continuous or static, meaning the tensile force is applied for a period of time and neither ceases nor increases or diminishes. It remains constant for a sustained period of time. But more researched and more evidenced would be intermittent cervical or intermittent traction, but particularly cervical traction. This would be alternating periods of sort of tensile force, relax, or pull, relax, with a much longer pull duration than a non-pull duration. Also available to the public and sometimes referred to patients will be over-the-door traction. However, this is non-mechanical, and this is typically limited to weights up to 20 pounds by volume of a water bag or a fluid bag that is suspended by a pulley system over the door. And these are designed for self-use or independent patient use at home. But one caveat here is that these do exert their pull force through the jaw and the occiput, so it is not rare to see aggravation of temporomandibular disorders and even the onset of suboccipital headaches because of that compression or the pulling force through those anatomic regions. Perhaps even lesser used, but still available for patients looking for it, would be pneumatic traction. Traction that is, a tensile force that is gained by some sort of pumping mechanism that might expand and allow some sort of tensile force to the neck. The fact of the matter here is that the tensile forces generated by pneumatic traction are well below what is necessary for a therapeutic effect. Now, in terms of the evidence for traction, historically, the lack of consistent evidence may be attributable to the inability to appropriately define the relevant subgroup of patients most likely to respond to mechanical traction. However, among experts, it remains consistent that if mechanical traction is used, it is most indicated for those patients with neck and upper extremity symptoms consistent with radiculopathy, and for those patients for whom centralization of that peripheralized pain is a preeminent treatment goal. So identifying the right patients for traction would help a great deal in the physician's identification of patients to refer for appropriate rehabilitation. So in 2009, Rainey et al. Published a paper in which they originally took 15 predictor variables and entered them into a regression and retained 5 for the eventual prediction model. And these 5 predictor variables were: 1, a positive distraction test. This would be the alleviation of symptoms upon a linear distraction or pull of the cervical spine. The second predictor variable was peripheralization or provocation or increase of symptoms with posterior to anterior mobilization of the vertebral bodies C4 through C7. Third predictor variable was the positive shoulder abduction test, which would be positive by the findings of alleviation of upper extremity symptoms upon placement of the palm atop the head. The fourth predictor variable was a positive upper limb tension test A. Now, upper limb tension tests are sequential series of joint movements of the upper extremity strategically designed to bias portions of the brachial plexus. And in specific, upper limb tension test A biases the median nerve distribution of the brachial plexus. And then the fifth predictor variable was an age of 55 or greater. Now with these five, these are the patients who are most indicated for referral to appropriate therapy and use of mechanical traction. Here's the findings from those five predictor variables. Rainey et al. Found that regardless of the number of positive tests from the five predictor variables, 44% of patients with upper extremity and neck symptoms improved with the use of therapeutic exercise and mechanical cervical traction. But in the presence of 3 of 5 of those predictor tests, that improvement rose to nearly 80% of the patients reporting improvement. In the presence of 4 of the 5 predictor variables, nearly 95% of patients improved with the use of therapeutic exercise and mechanical traction. So again, these are the patients for whom mechanical traction is most indicated. So a summary from mechanical traction suggests that it's most appropriate for patients with signs and symptoms of upper extremity neurologic involvement. That is the classic radiculopathy. The use for traction with low back pain is much less well defined in the literature, but again, among experts, it's more agreeable than not that radiculopathy seems to be a indication for patients likely to respond from mechanical traction. It is key to note that mechanical traction should be used as part of a comprehensive program. It is complementary to other therapies, such as specific therapeutic exercises defined in the literature, as well as specific techniques of manual therapy, again defined in the literature. Intermittent cervical traction is much more studied than static traction, so in terms of support, intermittent cervical traction gains that support. It does appear that the degree or magnitude of pulling force is somewhat dependent or patient-specific, and this requires some trial and error, for lack of a better term, to find the appropriate pulling force to alleviate the upper extremity symptoms. And as is the case with many therapies or interventions, better or continued identification of optimal parameters is needed. So let's move now to another widely used biophysical agent, and at one time was the #1 used biophysical agent in rehabilitation. And this would be ultrasound. And this is the application of acoustic energy. By ultrasound, I mean a frequency range well beyond the audible range of 20,000 hertz. Ultrasound, we're talking in the 1 million to 3 million hertz range. Ultrasound are sound waves, and sound waves transmit acoustic energy. And this occurs through the alternating compression and rarefaction, creating waves. And these sound waves can have both thermal and non-thermal biophysical effects that can be harnessed to elicit therapeutic effects. However, key to understanding the biophysical effects of ultrasound is to understand that ultrasound is best absorbed in dense collagen-based tissues versus water-based tissues. So structures such as tendons, ligaments, fascia, capsule, scar, these are highly collagenous-based tissues and absorb ultrasound very, very well, versus muscle tissue, which is a higher water-based content, which responds very, very well to pulsed electromagnetic fields. But that's not something that we have time to talk about in this session. So ultrasound for pain as a primary outcome, or using pain as a primary outcome to assess the efficacy of ultrasound, has been somewhat of a dead end or maybe a graveyard for ultrasound. The quality of studies has been historically extremely poor when ultrasound is assessed in this manner. That is, for ultrasound as a primary intervention for pain. And this has been somewhat of a plague. So I love the comment that ultrasound doesn't do anything. Well, let me show you the video in the upper left-hand corner where I have an ultrasound transducer head and I'm applying ultrasound underwater. And not only am I creating a projectile fountain of water, but there's also the aerosolization of those water molecules. In the upper right-hand corner, we see the row of candles there put out by the sound waves. And I'm sure that we've all experienced what it's like to be next to or inside a car with a booming sound system. Now imagine you're a fibroblast and you're being hit with that 1 million to 3 million times a second. You're going to react, you're going to do something. So you're going to do what fibroblasts do, and you're going to increase your activity producing connective tissue. So the problem with ultrasound is that it's typically used incorrectly and it's assessed in the wrong manner. So the reality for ultrasound is this: despite its primary use for pain, its primary physiologic effect is not analgesia. The primary physiologic effect of ultrasound is heating collagen-based tissues. Thus, it's more of a thermal agent. Thus, it acts to enhance mobility and extensibility. And I would suggest that these are the patients who need referral to appropriate rehabilitation professions who understand the role of limited mobility and extensibility in conditions that are ultimately resulting in pain. Ultrasound also increases activity of the fibroblasts. So in conditions with pain where production of connective tissue may enhance that condition, such as tendinopathies, activated fibroblasts become our friend. So the bottom line for ultrasound is ultrasound complements other interventions that may result in analgesia. And that I would suggest ultrasound is not a standalone intervention, but rather it is a tool within your toolbox to complement other interventions. When used in this way, the evidence looks a lot different for ultrasound, and ultrasound is much more substantiated. So let's talk about the most commonly used biophysical agent for pain management. This would be TENS, or transcutaneous electrical nerve stimulation. So let's talk about the mechanisms for Electro Analgesia. TENS is the delivery of electrical pulses across the skin with the intent to provide Electro Analgesia through depolarization of peripheral nerves. This is the A-beta input that we mentioned earlier. So Electro Analgesia is not new. It's been around for thousands of years with documented reports of the use of electric catfish and electrical eels. But it wasn't until the late 1800s we saw the first manufacturing of modern stimulator. And ironically today, the guts of the internal mechanisms of these things really haven't changed that much. So let's talk about the analgesic mechanisms of TENS, which to the surface appear very simple in the application of TENS. But there's a lot more that meets the eye here, and I'd like to be able to tell you about that. So in its simplest form, TENS is the application of varying electrical impulses to interrupt or modulate peripheral and central transmission of the nociceptive input from those A delta and C fibers. Now, TENS is commonly divided into low and high frequency. Low frequency is defined as 10 or less electrical pulses in a second. The analgesic mechanisms of low frequency TENS shows us that we have activation of descending inhibitory pathways, resulting in a descending blockade of pain. Evidence shows us that with low frequency TENS, we see preferential activation of mu opioid receptors in the periaqueductal gray, rostroventral medulla, and the spinal cord at that substantia gelatinosa, and in those peripheral nociceptors, those A delta C fibers. With low frequency TENS, we also see the activation of serotonin, GABA, and muscarinic M1 and M3 receptors. GABA, one of our inhibitory or hyperpolarizing neurotransmitters. Muscarinic receptors implying activation of parasympathetic activity. Low frequency TENS also shows activation of the alpha-2 adrenergic receptors, resulting in inhibition of the release of norepinephrine, thus suppressing sympathetic activity. So suppression of sympathetic activity, activation of parasympathetic activity, these are some of the reasons that low frequency TENS is supported in providing electroanalgesia. Now, high frequency TENS is typically defined as a frequency of 80 to 100, maybe 120 pulses in a second. It is high frequency TENS that shows activation of ascending inhibitory pathways, resulting in an ascending blockade of nociceptive input. Through high frequency TENS, we see the activation of delta opioid receptors in the rostroventral medulla and in the spinal cord at that substantia gelatinosa. We also see activation of GABA, muscarinic M1 and M2 receptors in the spinal cord. Also with high-frequency TENS, we see activation of the alpha-2 adrenergic receptors, again inhibiting the release of norepinephrine. And with high frequency, we see increased release of beta endorphins and enkephalin, or natural opioipeptins. And we see a decrease in the release of substance P. Now, this idea of receptor specificity for TENS is well supported in the literature. And it is through use of our opioid competitive antagonist drugs, naloxone and naltrexone, that we find support for this receptor specificity of high and low frequency TENS. Naloxone has an affinity to the 3 primary opioid receptors, but has particular affinity to the mu opioid receptor. When naloxone is administered following the application of TENS, the analgesia provided by TENS is reversed by naloxone, but only for low-frequency TENS, providing evidence that low-frequency TENS is specific through the mu opioid receptor. In this case, the high-frequency TENS still provided analgesia in the presence of naloxone. When administering naltrexone, which has a very high affinity for the delta opioid receptor, naltrexone will reverse analgesia induced by TENS, but only for high-frequency TENS, while low-frequency TENS is still effective in providing analgesia. This provides the evidence that high-frequency TENS provides analgesia mediated specifically through the delta opioid receptors. So the takeaway point from this is TENS works on the very same receptors as the opioid drugs. Now this leads us to the concept of analgesic tolerance and receptor cross-tolerance. Opioid drugs bind opioid receptors, and with repeated use, we can develop analgesic tolerance, which is that period of temporary decrease or temporary desensitization or non-responsiveness of the opioid receptor. With repeated use of TENS, we may also see the onset of desensitization in those very same receptors. Much like drug cross-tolerance results in an increased tolerance to a different drug, receptor cross-tolerance through the application of TENS can occur. With the administration or use of low-frequency TENS, we can see cross-tolerance in the mu opioid receptors. With the application or administration of high-frequency TENS, we can see cross-tolerance developed in the delta opioid receptors. So, keeping in mind that most opioid drugs bind to mu opioid receptors, the onset of tolerance in the mu receptors will make opioid users typically non-responders to low-frequency TENS. Evidence suggests that chronic pain patients using opioid medications respond to high-frequency TENS, but not low-frequency TENS. If no opioids are currently being used or recently used, evidence suggests that patients will respond to both high and low-frequency TENS. So the bottom line here is when choosing a frequency, it's essential to know if the patient is or has recently been using opioids, as they will be non-responders or typically be non-responders to low-frequency TENS. So using a TENS stimulator, let's talk about the basics of how to use one. Again, to the eye, use of a TENS unit looks very, very simplistic, but there's more to it, specifically when we understand some of the neurophysiology. So let's proceed through this. The anatomy of a TENS unit does not look very intimidating at all. It's typically a little small battery-powered portable device that might look like something many of us clipped on our belt years ago as a Walkman or some sort of portable music device. These devices deliver continuous electrical impulses, and the devices may be analog or digital depending on the manufacturer. And then TENS works through electrodes. Typically adhesive electrodes applied to the patient's skin, which serves as sort of the final interface between the electrical stimulator and the patient's tissues. And then TENS or the TENS devices operate off parameters. The 3 basic parameters of a TENS unit have been called the Holy Trinity of TENS. The first of these would be frequency, or the number of pulses delivered per second. This is where we see selection or the differentiation between high frequency and low frequency TENS. So low frequency TENS being 10 or less pulses per second, high frequency TENS being 80 to 100, 120 pulses per second, which is easily choosable with the appropriate dial marked, in this case, pulse rate, or it might say frequency. If no opioid medications are in the patient's current picture, then the patient's likely to respond to high or low frequency, as substantiated by animal and human studies. But if opioid medications are present, evidence in animal and humans say they are not likely to respond to low frequency. A second parameter of TENS is the pulse duration. This is the amount of time that each individual pulse lasts, and this is in microseconds, which is a relatively small time. But in electrophysiology world, it can be a relatively long time. What we know is that at the longer pulse duration, the sensory threshold becomes closer to the noxious threshold. So it is recommended that we use a pulse duration somewhere between 100 and 200 microseconds, and this will appear on most any TENS unit available in the United States. And then the third of the holy trinity of parameters for TENS is the amplitude. And I will refer, and I would like you to think of the amplitude as the dosage. And this is probably the one area where clinicians as well as patients fail to fully capture the benefit of electroanalgesia through TENS because they simply underdose the treatment. The recommendations for amplitude are to increase the stimulus to a strong but comfortable or strongest tolerable intensity. At inadequate intensities, the evidence does not support TENS, and it is simply thought of as underdosed. So too often, patients are instructed to turn the stimulus up until they feel it and leave it there at somewhat comfortable, but it should be turned up until it's as strong as tolerated or strong but comfortable. Anything less is underdosed. Electrode placement with TENS has been described somewhat as much a combination of science as it is art. The most common electrode placement will be directly over the site of pain, but can also be adjacent to the pain. The electrodes may also be placed over the peripheral nerve innervating the painful area, so the same nerve root level. And the electrodes may go proximal or distal to the actual site of pain as long as the stimulus from the TENS is propagated on the same peripheral nerve. The electrodes may be placed paraspinally at the same nerve root level as the pain. And electrodes may be applied dermatomally, myotomally, or sclerotomally. And a lesser known but effective placement is contralaterally over the same nerve root level. So for example, with C7 radiculopathy on the right side, electrodes could be placed at the C7 nerve root on the left side of the spine, with some evidence still substantiating that electrode placement. When to use TENS is a common question. Well, more recent evidence has supported our conclusion here that TENS reduces movement pain better than resting pain. TENS is effective with resting pain, but it's more effective with movement pain. Recent studies have shown that pain with movement in 6-minute walk test or 5 times sit-to-stand test reduces pain more effectively with activity than at rest. So the point here being, TENS is best used during exercise or during their rehabilitation therapy. The typical treatment duration for TENS is not as well evidenced throughout the literature, but the first treatment anecdotally is recommended to be somewhere between 10 and 30 minutes, simply as an acclimation period. During this acclimation period, the clinician would assess the tolerance, and that is the patient's sensory experience and tolerance to the stimulus, especially understanding that in terms of dosage or amplitude, we want strong but tolerable, strong but comfortable. We also assess the initial benefit of the TENS. Because TENS is electricity, we have electrothermal and electrochemical responses that may manifest at the skin under the electrode. So we would like to assess the skin response. And we would also like to assess the patient's ability to self-administer the TENS unit if the unit is to be dispensed for individual or independent use at home. And then subsequent treatments vary but are generally recommended between 10 and 60 minutes. Studies several years ago offered support that 40 minutes was an ideal or more optimal treatment duration for patients with knee osteoarthritis. But the breaks, so the intervals between treatments within the day also gives the skin time to recover and gives the patient or the clinician time to assess skin integrity. How long does TENS last? Another common question. Well, TENS works on the very same receptors as the opioid drugs. So like drugs, TENS works best when it's on, like a dosage. There is no half-life for TENS per se, as there are for drugs, but we do see extended benefits with TENS from minutes to hours. It tends to be a much more individualistic response. And like many drugs, we tend to have those that are considered responders or non-responders. To prolong the effect of TENS, we can do a few things. Again, addressing the dosage or the intensity, increase the amplitude within the treatment session or over subsequent sessions over the same day. Most TENS units have features that allow modulation of the stimulation, as noted here in the middle with this slide bar that says mode B, N, and M. These allow for modulation of the frequency, maybe between high and low. And this can help us avoid analgesic tolerance or sensory habituation. Two different neurophysiologic events that collectively decrease the effectiveness of Electro Analgesia. And then the third recommendation that works for some patients, but not all, is to change the electrode placement to one of the previously mentioned electrode placement sites. So as with drugs or many treatments, there are a variety of contraindications or precautions. I would like to advise you that treating pain of unknown or unidentifiable origin is generally considered a contraindication to TENS. Masking or covering pain that should be more appropriately treated through different mechanisms can be considered a contraindication. In general, because TENS is an electrophysical modality, placement over other implantable electrical implants or electrical devices is not recommended. It's also recommended that we do not apply electrical stimulation over or near active or malignant tumors, although there is tremendously positive support for Electro Analgesia in the palliative care or palliative stages of cancer. Patients with seizure disorders should be screened to determine that they are not going to, we're not going to set off a seizure. And pregnancy is also considered a contraindication because we do not fully understand the impact of electrical stimulation if applied over the lower abdominal region, uterus, or the lower back. Although, as with cancer, there's tremendous evidence for the use of Electro Analgesia during labor and delivery. And then cognitive or learning impairments. If a patient is to be given or a TENS unit is to be dispensed for independent use at home, it is critical to understand and make sure that the patient is capable of operating this device appropriately. So the general recommendations for TENS are this, if we summarize it this way. The frequency can be high or low, alternating between applications. The intensity should be as high as tolerated. The duration, we can average out the recommendations to 20 minutes. The electrode placement is most commonly at the site of pain, but with other options. Application should be during physical activity or exercise. The drug interaction awareness leads us to recognize that if opioids are present, high-frequency TENS is supported more by the literature. And the selection of the clinical population would be those with enhanced excitability and loss of inhibition, or those with elevated pain syndromes. So lastly, my recommendations for referrals and recommendations. There are a variety of over-the-counter TENS units that have hit the market in the last several years. The bottom line for these is while they are relatively affordable at under $50 or less for a single channel TENS, these are far underpowered. Most of them have 50% or less of the power of a commercial device, ones that might be dispensed from a medical facility. Most of these over-the-counter ones have limited features and thus limited use or duration of use. Prescription units may be more costly, and a prescription or referral may be necessary for insurance coverage, and a referral may be necessary for a rehabilitation institution to release a TENS unit to a patient. But I would put a plug out here for the physical therapy and occupational therapy for professionals who have received this education within their curricula, and so they will be good resources to consider. In terms of Medicare, we understand that with acute post-op pain, they would cover a 30-day rental, but with chronic pain, it appears that One, it has to be greater than 3 months and have demonstrated failure of other treatments. I have left here for you a few resources if you have further interest in looking up the role of biophysical agents in a whole slew of biophysical effects, not just specifically analgesia. It has been a pleasure to be here this morning, and thank you very much again to the organizers of this conference.